Good afternoon and good evening. Welcome everyone to this first American Journal of Transplant Journal Club series on T-cell mediated rejection, overlooked and underappreciated. I'm your host and also panelist, Rosalind Mannon. I'm a transplant nephrologist at the University of Nebraska Medical Center. I'm joined today by an esteemed panel of colleagues who will be participating in our live panel session. Dr. Sindhu Chandran, who is an associate professor of medicine at UCSF in the Division of Nephrology and an associate editor at the journal. Michael Mengel, professor and chief of the Department of Laboratory Medicine and Pathology at the University of Alberta, also an associate editor. Dr. Parmjit Randhawa, professor of the Department of Pathology and Transplant Pathology at the Thomas Starzl Institute of Transplantation at the University of Pittsburgh. And finally, Ilkka Hilantera, an associate professor of medicine, also a transplant nephrologist at Helsinki University and an associate editor at our journal. I hope that you've had an opportunity to read the two papers published last month on T-cell mediated rejection, the study by Ho et al., The Effectiveness of T-cell mediated rejection Therapy, a systematic review and meta-analysis, and the second paper by Christine Rampersad, The Negative Impact of T-cell mediated rejection on Renal Allograft Survival in the Modern Era. If you haven't, we'll cover for you. But we also, because I'll give you a little intro, but we also have a YouTube video shown here, which will allow you an opportunity to hear the authors talk a little bit about their paper, each about 15 minutes, highlighting their methodology, their background processes of thought, and what they identified and found in their paper. So why T-cell mediated rejection? I think most of us recognize that the frequency in kidney transplantation is about 5 to 15% clinically in the modern era of immunosuppressive therapy. And I think we tend to think that it doesn't happen very frequently. And moreover, it's a vanishing endpoint for clinical trials, and it's really limited innovative therapy. However, for those centers that perform surveillance biopsy, the frequency of subclinical rejection may be as high as 30% after transplantation. And moreover, this subclinical rejection has a negative impact on long-term graft survival. Interestingly, a recent survey data from North America from two different countries on T-cell mediated rejection demonstrated that the data do not align with KDIGO treatment guidelines published in 2009. There had been limited clinical treatment of borderline rejection, for example. There is inconsistent use of T-cell depleting therapy at the time of rejection, sometimes based on difference of Banff grading. And finally, the success of treatment has been predominantly associated with return of renal function, which is not consistent, and/or biopsy, which is even less frequently utilized. The first of two papers by Ho et al. Looks at how, following treatment, how often does T-cell mediated rejection persist, and whether this is related to the original Banff grade of rejection diagnosed at the time, and whether the presence of clinical functional change or whether this is surveillance subclinical rejection makes a difference in terms of outcomes. They performed a systematic and literature analysis, ended up with 12 studies that were identified for their meta-analysis, and demonstrated that 39% of individuals had persisted greater than or equal to borderline rejection after treatment for at least a Banff borderline. That was almost 600 subjects, regardless of the grade of the primary event. Similarly, and also they found that there was a 46% persistence of at least a Banff borderline rejection after treatment of subclinical rejection of at least Banff borderline grade, a much smaller number. And it was slightly lower persistence, 41%, when the original event was a clinical rejection. Again, showing some similarities that there was a persistence regardless of Banff grade, and a pretty high frequency at that. The second study by Rampersad et al. Looks at the impact of T-cell mediated rejection. Is there a clinical impact to the first episode, and does the Banff grade matter? And what is the impact of a second episode, and does it matter whether it's persistent before or after 6 months? This is a monocentric study of the Manitoba group, 1,685 biopsies, about 808 patients, primarily only including those decades where they included surveillance biopsy. More than 50% of individuals that had T-cell mediated rejection had another eventual event. In fact, if you look at that paper, there were some individuals that had up to 10 events. And they associated recurrent T cell mediated rejection, interestingly, with mismatches through HLA, DR, and DQ. They did an extended proportional hazards model adjusted for baseline covariates, and both first and second T cell mediated rejection events were independently associated with death-censored graft loss. And the second TCMR event had a negative impact both on death-censored and all-cause graft loss, regardless of persistent or subsequent episodes. There's a lot more data in that paper, and I would encourage you to read it. Includes analysis of the impact of delayed graft function. So with that, I'm going to end the slide presentation, and I'm going to welcome my panelists to join me live. And I'd like to encourage you to put your questions in the Q&A rather than the chat, so we can have a lively discussion. So Dr. Randhawa, put your camera on. Dr. Hilantera, Sindhu, you have your camera on. You're so good. Mike Mengel, we want to see you.
Yeah, no, I need permission from the host. Because
okay,
yes.
We'll get it for you. As we're waiting, Sindhu, you know, you had a lot of interest, I think, in these papers, mainly from a research perspective. So just give me a little bit of your perspective when you read these in terms of impact on clinical research.
Yeah, I think that this has always been a kind of interesting topic for us at UCSF. We started surveillance biopsies about 10 years ago or so in our transplant patients. And, you know, this is something we encountered also. And that one thing that was striking to me was that, you know, in the paper by Dr. in the paper by Dr. Rampersad, which is a single center study of 775 kidney transplant recipients, they had about 50% or less of the patients received antibody induction, and they were all maintained on Taxol, Cept, and prednisone. Whereas in our own experience at our large transplant center, we have seen, you know, most of the patients, almost all of them get antibody induction, and about 60 to 70% are maintained on prednisone. We had remarkably similar findings, and this has been, I think, also seen in other cohorts which have reported the results of their surveillance biopsies, the presence of subclinical rejection being about 30% or so, and of clinical rejection being about, you know, 5 to 15%, as you noted, on cause biopsies, but about, you know, 15% or so on surveillance biopsies. So it seems interesting that despite these variations that we have in center practice patterns regarding immunosuppression, that overall, in this era of modern immunosuppression, we still see quite a bit of inflammation under the tip of the iceberg. So I think that's one of those things that seems to be, you know, that struck me from this paper and from the experience of Dr. Ho's paper also.
Well, we have two esteemed pathologists with us, and one looks extremely skeptical, Michael Mengel. So tell us what, you know, your thoughts were sort of globally about these papers. And certainly there's a lot of tangents we could take, whether it's the impact with IFTA or just the overall Banff borderline scheme and behavior of these patients in these studies, indicating that most of this Banff borderline looks like it was alloimmune in nature.
Yeah, that the role or the nature of Banff borderline is a matter of debate since Banff exists in 1991, and the original paper, it already has essentially triggered the discussion of where is the fine line between over-immunosuppression and adequate suppression of persisting inflammation. And that's the one challenge we haven't really resolved yet. But what these papers show and the data from the Winnipeg group show is that even borderline can be a reflection of higher immunological risk. So they also correlated this with the applet mismatch, and that the persisting inflammation is then later associated with an increased risk for de novo DSA. So I think it is important not to see this inflammation in the biopsy as an isolated event only, an episode of rejection, but rather as a reflection of the immune status of a patient. And that is, as you allude to, also the DCAF study showed is where this inflammation persists and later you have it in combination with fibrosis, it's a clear indicator of allograft survival. So I think it is a valid rationale or hypothesis to say, what do we have to do to abrogate this inflammation early on before it causes chronic damage or chronic immune responses manifested by DSA. And when we talked through that thinking, a key question came up and saying is, how do you define that you successfully treated inflammation? And I think that's the other major message of these two papers is neither the BANF system nor the clinical community has a very solid definition of successful resolution of either borderline or BANF 1A, 2A, TCMR. And I think that's the efforts we need to start to say whether any revised therapeutic intervention of these early inflammatory episodes are successful, because we can't wait 10, 15 years like the DCAF study did to say, okay, it extends allograft survival.
Mhm.
So I think these two papers really nicely summarize one big problem we still are faced with in kidney transplantation of how to adequately control the immune response.
And certainly I can switch this a little more clinically. Ilka, do you see in Europe that the treatment of rejection is predominantly defined as whatever your center does, and then you follow up and say, creatinine better, it's all okay? Or is there a consistent use of rebiopsy? I can say here and at my prior institution, I think when people didn't go down to where you expected, whatever that may mean, or the grade was really high. I mean, if I saw a lot of edema or hemorrhage, I knew function was not going to be dropping dramatically. How do you handle those patients, or do you have a consistent pathway for management?
Well, that's a great question, because I visited many centers in Europe, in Scandinavia and Central Europe, and every center has their very own protocol of treating rejection and also deciding of when to take follow-up biopsies. And it's actually quite even amusing that even if we all give high-dose steroids, everyone has their own recipe of how many milligrams and how many days, and so there is certainly not any consensus of how to do this. We in our center, we've been taking follow-up biopsies after each rejection episode treatment, but the only reason for doing that is that because the guys who were working before me had always done so they just told me that you have to take a follow-up biopsy. But that's pretty much the only reason I've been doing that. So. But I think they really teach us a lot, because it's not always as we've noticed in these papers, that is quite often that the TCMR persists in the biopsy, but the next question is that what would be the optimal time point to take the follow-up biopsy? Because sometimes it takes weeks or even months to resolve, whereas sometimes it is already gone after 1 week. And does it make a difference if it's resolves quickly or more slowly? No one has an answer to that, I guess.
Well, I think it's striking to see the repetitive nature. Michael says, not an isolated event, and certainly the TOPA group shows this graph with repeated events. And so, Parmjeet, I know you were in on the discussion of chronic T-cell mediated rejection. I mean, is that, were we seeing repetitive events, or is this just sort of a transition into that terminology?
Yes, so I think if you look at the literature on chronic active TCMR, not all studies find, preceding episodes of acute rejection. Mm-hmm. And these authors have actually used that observation to argue against it being an immune event, but I don't agree with that. I think in the context of modern immunosuppression, we have damped down the immune reaction so they can slowly progress to chronicity. And what we now recognize as chronic active TCMR, if there are previous episodes of acute TCMR, yes, it supports your cases, but if there are none, then it doesn't argue against it. And in Pittsburgh, we do protocol biopsies at 3 months and 12 months. And we are surprised how often we see changes which meet the criteria of borderline in about 20%. and even 1A in about 10%. And we treat them, but our follow-up, we are really going blind. If we have 1A at 3 months, we treat it, then we don't really repeat the biopsy because you don't feel comfortable doing it. We do have a policy in place that if the protocol biopsy showed 1B rejection, then we do actually take the trouble of doing a follow-up biopsy about 6 weeks later. But for 1A, we don't. And that indicates an important lacuna in how we practice medicine. I think we absolutely need some sort of non-invasive way of monitoring, especially these subclinical rejections, because the creatinine is not available to monitor. And so there are several different ways of looking at it. And of course, there's excellent work from the Alberta group. And I really believe that this urine CXCL9 and other such metabolites should be used more often to monitor responses. And I personally also believe that the cell-free DNA assays should be standardized in urine, because that will be a perhaps much more sensitive way of monitoring subclinical rejection. In fact, the cell-free DNA people came to me several years ago, and I said, well, I personally prefer urine to plasma, but for some reason, they went on and actually developed in plasma, which has its own advantages. But for the problem that we are discussing today, I think a urine cell-free DNA assay would be really useful. And I also think that there's a low-tech way of doing it. And in my opinion, even a urinary sediment being examined for lymphocytes would be useful. Because when I was a resident, that was in the 80s, we used to monitor acute rejection by urine cytology. We would take the patient's urine, spin it down on a filter, look at the lymphocytes, and use those lymphocytes to make a diagnosis of rejection. Of course, it doesn't give you information about vasculitis or fibrosis. It has its limits, but in a low resource setting, those lymphocytes are there. And it used to work. And till these more expensive technologies become available, I have been trying many residents to get interested and look at the urine sediment and to see if we can come up with something, but none of them actually has taken the weight. But I still believe it's a low-tech technology which deserves, a further evaluation.
Well, probably they'd say, oh, it's not very specific, or it's not cool, because everybody wants to do molecular, wants to do transcriptomics.
Yeah, the specificity issue, I guess. Nothing is specific, but everything becomes specific after you've done a thorough examination and ruled out other causes. I think it was this excessive emphasis on specificity that delayed the recognition of chronic active TCMR for so many years. And we know it's not specific, but fever is not specific. But yet, after examining the patient, going through the clinical features, looking at the lab, we can always assign a cause of fever. So I look at it the same way. Many of these lesions, in fact, I believe whenever there's inflammation in the graft and there's no other explanation for it, it's reasonable to assume that it is immune.
Well, certainly, I appreciate your points about chronic active TCMR and was in favor of that classification. I guess the question is are those episodes, when you have an acute, like ABMR, when you have these early acute ABMRs, they are easy to treat. Is the treatment, first of all, we can't even agree on the treatment of acute TCMR, but the question is the treatment, how do we approach treatment to minimize or mitigate or avoid these follow-up episodes, chronic or otherwise? Does anybody have any thoughts about the current therapy? Is it a lack of standardization that we're missing here, or is it a lack of the best tools to treat rejection? And that's, maybe more to the clinicians. And you can speculate because, we're live. We can do whatever we'd like, except be, slapping each other like that, like Will Smith. We're not.
Let me give you a pathologist perspective here.
Yeah.
So much of what we call chronic active TCMR, clinically it is acute. The very reason we get these biopsies is because the creatinine rose from a baseline to a level which prompted the clinician to biopsy. So we can call it chronic active, or you can call it acute, but clinically it is all acute. And we do treat it the same way as we would a regular acute. And I think the survey done by Banff some time ago confirmed that. And of course, the response rate is going to be much lower for chronic active than for acute, simply because the kidney is in worse shape. Often there's a lot of fibrosis, there's a lot of arteriosclerosis. So it limits demonstrable response. And the number of people who respond, I think, varies in the range of 20 to 50% in different series. Again, depending on what is the real pathology in the setting of which the chronic active TCMR has been detected. And the same problem comes up because these patients are not going to be biopsied repeatedly. So you give steroids, and people who give steroids, they cannot really confidently say that we made a huge difference to the graft outcome, because those studies are very difficult to do. Even if they were done, differences would probably not show up without significantly long and fairly intensive follow-up. And it will be a mixed bag. Some people will respond, some people will go on to graft failure. And so our challenge again would be to try to identify a priori who's going to progress and who's going to regress or stay stable. And that, as you know, is a very difficult problem.
Yeah, I think in my opinion, the problem is that at least in our patients, which most of are unsensitized or lowly sensitized, so most of them respond to the steroids. And we know that from the follow-up biopsies, if you just wait for a few weeks before taking the follow-up biopsy, so usually it's gone only with the steroid. But we should recognize those patients who need some more treatment and give it early enough and not wait for the 1 month to see if it's resolved or not. So that is the problem. And I'm talking about acute TCMR. And I agree with Paramjeet that this chronic TCMR, that is a different thing in my opinion, because often if we take follow-up biopsies after some kind of treatment, no one knows what's the optimal treatment, but that is not at all often resolved. There's some level of information that stays. It might be in the scarred areas, but I think it's equally harmful in the scarred areas and not only the unscarred cortex.
So in our experience, when we see the chronic active TCMR, virtually all the inflammation is in scarred areas. And yet there's clearly an acute injury, acute event. And in our experience, I cannot say whether, I cannot compare the two, because virtually always it's predominantly in the scarred area, but I can say that about 20 or 30% of the time, the area and the scarred inflammation in the scarred areas does respond transiently. Whether there's any long-term benefit, I do not have the data to tell you. Yeah.
Sindhu, you had, I see you unmuted. Go ahead.
Yeah, no, I think I wanted to address one of the things you brought up, and Dr. Randhawa too, about the, how do we assess response, right? So I think one of the things is the lack of standardization, I think is very important, because it's really hard to compare apples to oranges. And when different, even ultimately these retrospective analyses do face this limitation of not knowing exactly what the therapy was and how to evaluate the benefits of different sorts of therapies. So we do need prospective trials. And I think where we include TCMR or either greater than or equal to BAMF borderline as the entry point for these trials. And I think that's one really important issue. And one of the studies that was included was one that we did at UCSF, and it was only 35 patients or so where patients were randomized who had subclinical borderline change at either tocilizumab or no treatment. And then we followed them up with a subsequent biopsy 6 months later, which again, brings the question, they got tocilizumab for 6 months. So I think that was hard enough to do with 35 patients. So I think it really tells you that we do need multi-center collaborative efforts to do these trials where we include people with this condition, and then go ahead and test therapies in a, maybe in a sort of a platform trial concept where you have different arms enrolling patients and, looking at therapies that work or don't work. And then the second question is, what is the signal, right, of success? So I think follow-up biopsies will be critical based on these two papers to identify histological improvement. And then I think, as Roz, you have pointed out before, there are emerging sort of endpoints that are being validated in Europe and potentially in the US, such as the IBOX score, which could be used to give us some short-term idea of whether or not these therapies are successful without having to wait years and years.
So Ross, I had a question for you because I didn't have a chance to review this paper by Ram Prasad very thoroughly. Obviously, to call persistent rejection or resolving or unresolved rejection, you need a follow-up biopsy. And presumably this study focuses on that bias group where the follow-up biopsies were deemed to be necessary. Do you know, is the paper actually say what proportion of people were biopsied, which were not biopsied, so we can put the data in some better context?
Yeah, they do.
19% were not biopsied.
19?
So
19.
Oh, I see.
19.
So that's pretty
yeah,
good.
so
They did
this was,
biopsy about
you know,
80%.
yeah,
Okay.
I mean, it's, you know, a single center where they had very specific treatment. You know, it's not a center with 7 or 8 clinicians running around like our chickens without our heads. It was very focused. And so I think it gives you a nice natural history course of things. But I want to just answer a question that came into the Q&A, because I think it's an important one. You know, we're presuming that this persistent inflammation, you know, I imply that it was not maybe great treatment, but one question is, how do we know this wasn't non-adherence? And is there a way to sort of say, hey, maybe this was brewing and it became non-adherent, and then we treat them with a hammer, and then we let the patient loose, and they're not really treating it. So I'm paraphrasing this question. I mean, one question is a chronic active really because, you know, patients just aren't taking their medicines over a long period of time, and that's open to anybody.
I think what supports that point, Ross, is that in, let me just check, figure 6 of the Rampersad paper, you can see that there is consistently around 15 to 20% of the patients who have a low immunological risk, but still have persisting rejection. And I would just speculate that those might be patients being under immunosuppressed for whatever reason, right?
Mm-hmm.
Compliance is the default bias assumption, but it could be that they have comorbidities and cannot take certain immunosuppressive drugs. Since this is a study in Canada, they all will have access to drugs, right? Publicly funded. That's excluded, but I think this is not all one size fits all. We have patients who have, for various reasons, persisting immune response. Either they are high immunological risk, which gives a rationale, where there is inadequate immunosuppression for other reasons, but without high immunological risk, or a combination of both. And makes me wonder that we see the same pathology, but will the treatment approaches be always the same? Right?
No, I think that's an excellent point. And I was just at the ASTCOT meeting, and one of the questions for Chris Wiebe is like, why does DRDQ mismatch matter when cellular rejection is a CD8 cytotoxic T cell driven response? Isn't this really more of a mismatch of class 1? And the answer, I'll paraphrase, is that those studies are underway to look at that. But maybe this is just a marker of those people that are going to do poorly, and maybe there is a link. I don't, you know, I don't study human HLA well enough to know why that is the case. I again thought, yeah, why is it class 2? But along those lines, again, you know, we don't have great ways of monitoring for non-adherence. What do I use? I use a tacrolimus level, and you know, how many patients maybe have a genetic issue where their pharmacokinetics are a little off, or they're just not taking it, and they just don't feel comfortable taking it. Now that in the US, we do have the affordability issue taken care of because lifetime medications provided for kidney, and that makes, I think, a big improvement. But I do think that the therapies for rejection, you know, that's something I think we could probably talk about. I see Sindhu raised her hand, so she may have another point along those lines.
I think I had pretty much, I just wanted to second what Dr. Mengel said about, you know, it not being all or none, and that there is this module, it's a combination ultimately, and both the group from Colorado as well as Dr. Nickerson's group also has shown, Dr. Wiebe's group has shown the same stuff, that tacrolimus exposure modulates the sort of, you know, the influence that molecular mismatch has on these, and, you know, on the biopsy outcomes, the development of de novo DSA, and so on. So that it may be that a low risk patient who is non-compliant, like you pointed out, is ending up in this bucket of having persistent rejection, and a high risk patient ends up there despite being compliant. So I think these are interwoven factors, and it may be hard to sort of piece out exactly each the isolated effect of each of these, but ultimately the pathology may not be that different, although the response to treatment may be, as Dr. Mangal said. So
I have some thoughts about this DRDQ, mismatch.
Yeah.
And I think it can be used to perhaps argue that CD4 cells are more important in T cell mediated rejection than we think. In other words, we know from immunity to viral infections, T cells can process both class 1 and class 2 peptides. And I really see no reason why this should not be happening in the context of a alloimmune reaction. So they are probably, so that's one aspect. And the other aspect to keep in mind is that ABMR and TCMR are closely linked to each other, and one can lead to the other. For example, if there's antibody-mediated injury, the tissues will be damaged, new epitopes will be released. These new epitopes will be recognized by T cells. So that will, accelerate the damaging process by, putting an overlay of TCMR on ABMR. And then the damage, of course, can release additional antigens to which new antibodies might arise. So it can be a vicious self-perpetuating process. And one of the reasons why some people do not respond could be a situation analogous to the Brenner's hyperfiltration hypothesis. In other words, after a certain threshold of damage has been reached, ABMR kicks off TCMR, TSMR kicks off ABMR, and that cycle progresses without any further, need for stimulation.
Ilka, go ahead.
Yes, I agree completely what's being said here, because especially with antibody-mediated rejection, our patients who have severe antibody-mediated rejection usually have preformed DSAs at the time of transplantation. With these patients, we quite often see that no matter how hard we treat them with all the possible drugs our pharmacist can find in the hospital, they still, some level of inflammation persists in the biopsy. So I guess the same phenomenon could be seen in TCMR. Maybe it's some factor that we don't know yet. Maybe it's this epileptic mismatch, but there is some driver that is just keeping the inflammation going on. But we just should identify these patients somehow. And another point to this non-adherence I would like to make is that I like what Michael just said, that it's not only non-adherence of the patients, it's quite often, especially during the early or the first year in our center, is that if we see findings in protocol biopsies information, it's not the patients who've not been taking the medications, but it's us nephrologists who've been weaning the immunosuppressant for some reasons. Usually it's infections or BK virus or CMV or other issues with not tolerating the drug. So it's not only the patient's fault, sometimes it's our fault that we've kept them on too low level of medication.
So I want to, I don't know if the rest of the audience can see this, but Steve Wodel, who's attending today, has a very thoughtful, insightful, mechanistic comment about persistent rejection. And he notes that in their program, when they do serial biopsies, they've analyzed by single cell RNA-seq, and they see a high degree of restriction of CD8 T cell clonal expansion based on TCR sequencing, and identify 5 to 10 or fewer unique TCRs that persist, and they persist on serial biopsies. And so that kind of data, as he states, supports the notion that you don't eliminate the expanded clone that's causing the trouble, or clones, and that's maybe one reason why there's a persistent rejection. And you're right, CD4s are activated because the DRDQ mismatch, there's CD4 positive T cell help, and then you have this nidus of inflammation that can start to take off. So appreciate that comment, Steve. And I really do think that we're using like hammers to treat rejection. And I'd really like us, to think out of the box about the opportunity to define new therapies. And, doing more short-term acute rejection studies would be something I'd encourage. I can't tell if industry is participating today, but industry representatives, I wish they would start thinking about this rather than the long term, which is important. And that's what the iBox may help us as a surrogate endpoint for clinical trials. I don't know if you guys have thoughts about, Sindhu, your group has really tried to sort of focus rejection management, Tregs, novel anti-inflammatories. Any comments or thoughts?
Look, Ross, before Sindhu comes in, what you just said in a casual sentence is to me a fundamental dogma shift in our field, which I think requires a lot of change.
These things come out of my mouth. And
yeah, you just try to slide this in, shifting the landscape of transplantation, but it requires a lot of change management with all stakeholders, because our field for 50 years sees T-cell mediated rejection, biopsy proven T-cell or antibody mediated rejection as the endpoint. What you just said to me is the endpoint is successfully managing the episode.
Mm-hmm.
Right? We know many drugs in the field, and you wrote a very famous and highly cited paper about the pipeline of drugs in the journal. Many of these drugs died on the vine because of this endpoint. Mm-hmm. Instead of asking the question, are these drugs suitable or a combination with other drugs to manage a rejection episode? And maybe we do not have to invent new drugs, but rather go back to those which regulatory agencies, based on this potentially outdated endpoint, killed and abandoned. And it might even be better for the community because they are now off patent.
Right.
So you could repurpose immune modulatory compounds in a different design setting of trials which can be done collaboratively, as Sindhu said, is by academic centers without $500 million budget, right? So I think that's where our community has to come together and think differently when we readjust the endpoint, as you said, combining the management of a rejection episode with a surrogate endpoint for long-term outcome, I think justified, and molecular markers of indicators of injury, because we know that these persisting episodes of inflammation, the main driver of outcome is not the inflammatory transcripts, but it's the tissue injury transcripts. So when we measure that tissue injury goes down, mm-hmm. right, we would know that we mechanistically did something to preserve nephrons, and that should translate in the iBox to long-term. So I think we do not need new drugs. We need to revisit existing compounds in the field in a different framework.
Parmjeet, I know
I think another thing that we overlook, and I think it's hampering improvements in graft survival, is that there are investigators who, as soon as they see antibody and as soon as they see 4D, say, this is antibody-mediated rejection. Whereas many rejections are mixed, and this is a definitional problem, a perceptional problem. In Alberta, and I'm not meaning Michael Mengel, I mean, I'm referring to Halron series, he sees mixed rejection only in 5% of cases. Paris sees it in 70% of the cases. Some people say antibody is responsible for graft loss in 60% of cases. I would say antibody contributes to graft loss in 60% of the cases, or in all 60% of the cases, T cells are also involved and intermingled and contributing to the damage. And this excessive emphasis on ABMR, in my opinion, actually deprives many patients of T cell therapy. There are no good therapies for antibody. At least we have better therapies for T cells, and just calling everything antibody rather than mixed, I think, is a disservice to the community and is hampering proper patient treatment.
And I will say that you have said this at more than one BAMF meeting for historically. And I just think it's, I have to say, when you're older, you sort of feel more confident when you're treating patients, maybe. But even at my, when I would see a DSA on a 2A, a new 2A rejection, and I'd say, of course there's DSA. These people have like a bad rejection. Like, what do you think? The issue is get the T cells under control. And, you want to give IVIG, go ahead, I don't care. But this is not a primary antibody-mediated driven event. And the reason I think these concepts are really important in our transplant patients is that when Xeno comes online, if you think that this is going to be complicated, there's going to be a lot of clinical inflammation they're really focused on antibody. I get it, But I think the biggest hurdle is going to be simmering inflammation coupled with ABMR, because we're going to respond to pig protein. Sorry, I said it.
But nevertheless, it's important to separate them out, because I think we have enough evidence to understand that treating those or intervening with those two arms of the immune system requires different strategies and approaches, right? Just saying, oh, it's mixed rejection. My concern is going back to the one size fits all instead of going to a more tailored and mechanistic based therapeutic approach, right? So I hear Parmjeet, but I still advocate for saying we should separate them out. But that doesn't mean jumping to conclusions, as you said, is that one is superseding the other, right?
So absolutely, I agree with you, Michael. But I would argue pure TCMR is an uncommon event. Pure ABMR is an uncommon event. The vast majority are mixed. So I'm not disagreeing with you. I'm just saying that a lot of times they just are together and we need to recognize that.
Yeah.
But I think steroids is perfect treatment. It has effects on all pathways of the T cell activation. So that's perfect treatment, even if we don't know exactly what's going on. But we should start with steroids, and so that's the easy question. But it's the next step is the more difficult one.
And I don't disagree. I mean, I think to focus on the treatment success as the endpoint, we have to have a standardization amongst the community where we're comfortable saying, do we really need 500 times 4 of corticosteroids? Can we do 250 times 4? Like, where did that come? We used to use a gram. Again, that was what I used a gram, and good luck. And then you'd go to OKT3. And I've had an opportunity to look back at some of these really old OKT3 papers and realize, boy, that drug really worked. I mean, the more side effects patients had, the more you felt like something was really happening. But again, I think the community has to embrace some sort of standardized therapy to which compare new therapies to, if that's a consideration. And I think, Sindhu, I know that your editorial really argued, as you know, the endpoint was the endpoint. It's the starting point.
Yeah, I just want to point out though 2 caveats to that. One is that, from the benefit studies and the belatacept experience, we have to be mindful of using, sort of understanding that many of these papers on surveillance biopsies, subclinical TCMR, progression, chronic active TCMR come from predominantly CNI-based regimens. And that, the use of this endpoint would have, for instance, in the benefit trials where rejections were more common and more histologically severe in the Bella arms compared to the CNI arms, could be potentially, lead us down the wrong path if we kind of, look at the rejections in just an isolated framework of their pathology. But the response of rejection to treatment is important endpoint, and the association of rejection with the development of DSA, that is also another important consideration. So I think that while it remains an important endpoint, I think that we still have to be mindful of that. And the second thing is in terms of treating these rejections, I think as Dr. Woodall pointed out, I think the use of more sophisticated markers and these mechanistic sort of analyses and transcriptomics in the biopsies may give us more precise information about the kind of mechanisms that lead to persistent rejections in some patients and whether or not a particular therapy is influencing the outcome. So I think follow-up tissue in the absence of non-invasive markers right now, at least really robust non-invasive markers, is still going to be an important consideration for all of these trials where we are looking at the effectiveness of therapy. And that's something that the field hasn't embraced. As you pointed out, 70% of people think that, just having an improvement in the creatinine is sufficient to call it resolution. So to do these trials will be difficult without having to, consider all the apparatus that is necessary in terms of follow-up biopsies and so on.
And certainly for investigators to feel comfortable saying to a patient, we're putting you, we'd like you to do this trial, but the trial requires a follow-up biopsy. And to say, my center doesn't typically do it, so this is going to be different, or at least to say, we're going to monitor you using, a follow-up biopsy, which I don't think is unreasonable because we certainly do it for natural history, clinical practice management. Ilka, but I could go blabbing, so let somebody else talk.
Yeah, so maybe it's an obvious comment, but for if we think of some non-invasive biomarkers, so it's not enough that people validate and qualify it as a biomarker of rejection. We should also validate that it responds to treatment and it correlates also to the treatment response and not only to the baseline findings. So that's another issue. So since we don't have that yet, we still need to follow up biopsies even before we can validate a biomarker to use in this treatment response.
Well, before we end, I want to go back a little bit about biopsy transcriptomics. I think Parmjeet made a comment, Michael, can we use our transcriptomics now in a position, Steve Woodall's data for as an example, but is there a way that a standard transcriptome panel, pick your favorite, could actually be helping us that, I've always thought about them as saying, oh yeah, that concurs with what the pathologist saw. I wasn't thinking, are there prognostic features that may be helping us, or is there a transcript set that we're missing that could guide therapy or remind us, hey, there's insufficient therapy? Have you thought? Yeah, I guess you've probably thought about that.
Yeah, look, what pathology is not good at is assessing acute tissue injury, which is clearly the downstream effect of any inflammation in BK or a rejection. So the question here is that, and in many organs and diseases, the extent of cellular dysfunction like transportation, metabolism, in heart failure, cancer, and transcript rejection are associated with prognosis. The unknown question here is, do these molecular changes normalize under certain therapy, right? And does that translate to efficacy of a therapy? So, but I think that's where clearly molecules are superior to morphology. You can't see how injured an nephron is, how much the glucose transporters and solute carrier transporters are down. And that's why the creatinine goes up. So then it begs the question, are the molecules for $3,000 better than a creatinine, right? At the end of the day. And that is or cell-free DNA is the same. Damaged cells release the cell-free DNA and we measure that damage. And what's the time connection between your treatment and normalization of those and how? So these things need to be studied, but I think that's where molecules hold promise. And of course we know, and so there are some preliminary data that when you treat a rejection episode and do a follow-up biopsy closely to it, the molecules respond, so to say, quicker to treatment than does histology with actually the cells disappearing out of the tissue. And those are things we have not studied in a very rigorous way, right? To say what is the best practice around this. There is a lot of, as Ilka said in his opening remarks, is say that the practice he does is because the guy before him did it. So, and that's not different amongst pathologists, right? How we score tubulitis and how we score inflammation. And we haven't done very rigorous and randomized and detailed and standardized studies in these areas and to really address the questions we discussed today. So it's a bit really, I like what you said and Sindhu said earlier, this is not the end point of our research. It's actually the beginning of revisiting that space, because we now can take antibody-mediated rejection out of the equation. We understand it better. We understand immunological and molecular risk better, right? So I think it doesn't mean that we're going back to square one, but we look at something with different tools in a different stratified environment.
So we're going to run out of time, and before more people depart to their clinical duties, I just wanted to give each of our panelists an opportunity to wrap up or make any other points. So I'll start with you. I'll go alphabetically. So Sindhu, I'll start with you.
So I think I just wanted to sort of say how remarkable these two, papers have been in sort of continuing the story of the evolution of acute TCMR to chronic TCMR and looking at allograft loss and also the correlation with de novo DSA. So I think they illustrate the advances that we have made and the change in thinking that now has to occur. As you pointed out, we have swung towards the pendulum has swung towards saying TCMR is not a big problem and it's sort of vanishing, but it appears to, have reappeared on the horizon. And I think maybe it's not quite so much a vanishing endpoint if we start including borderline change in our endpoints and also using that as a starting point to move forward. So I think that would be my take on this.
Thanks. Ilka, any final thoughts or concluding thoughts you had?
Well, maybe in addition to what Sindhu just said, which I completely agree with, is that I think we need some kind of standardization or some kind of timeline that when would be the optimal time to take the follow-up biopsy. And so it's not enough we just treat TCMR or whatever rejection response it is. We'd also need to see that it's actually treated, and if not, then we need to consider additional treatments. And this is an area where there is not at all any studies, and this we need more data about.
And I have to say, I'm participating in a literature review in this area, and the data are really quite limited and really quite striking. And even in some of the stuff in my review group, even though some of these episodes are happening in clinical trials for new agents, there isn't, there's a defined what is rejection, but there's not a defined successfully treated rejection. And repeatedly you see in the discussion, well, 35% responded to this new, this way of treatment. And you're like, okay, how are they responding? So I think, having these papers helps and having surveys helps, but I think there's not great data to say 3 months, 6 months. And I actually have to go back to the KDIGO. I want to say that was expert opinion about follow-up. Michael, I know you have some strong opinions, and then Parmjeet, I'll have you wrap up last.
Although I had ample opportunity to voice my opinions today, right? It's just, I just want to echo that these two papers are actually meeting the standard of rigor we need to revisit this area. And as you pointed out, Roz, we started looking into this area for quite a while and understanding it, and it is somewhat shocking how weak the evidence base is for something what is done hundreds of thousands of times across the world every day, right? It's not evidence-based medicine for sure how we manage T-cell mediated rejection according to current standards of evidence-based literature. And especially in the era of precision medicine, we better catch up to this, I would say. And these two papers are clearly shedding the light on this. So I congratulate the authors for doing this research.
Parmjeet, any final thoughts before we go?
Lucky me, with the R, I get to say the last word.
Close, maybe me, but it's okay.
No, I would ask that the major league PIs in our community actually start implementing some of the ideas that we have discussed. If they need a pathologist, I will work pro bono.
All right, this is being recorded, so I'm writing that down, but I agree. I mean, I think this notion, we're battling for personalized care, but we don't have yet a care standard, which would put everybody in the same bucket. But then after that, response rates, I think, are really important, and understanding who's going to continue to have trouble, and maybe they have trouble in the first place because we bucketed them with everybody. And we said, well, they have zero mismatch, so they probably don't need a lot of therapy, but maybe they really aren't zero mismatch at a molecular level. We have so many new tools. Then when I trained as a fellow, as a resident, I once questioned one of the transplant surgeons when I was on consult, why are we using steroids? And he just said, this is the way we do it here at Duke. Don't go tell your attending. And I was like, oh, okay. And then you try to look it up, and you had to actually go to the library and open papers. And, that was just the way things were done. And so Ilka, that's, a lot of medicine is tradition, and tradition is great. That's how we got to where we are. But I think, now we're in a galvanizing in a new era, particularly using of computers and computerized data collection. Well, I want to thank all of the panelists for taking time out today to do a free-form discussion. It might have been a little disappointing for the attendees who might have expected more of a spoon feeding. So I would say that they could go back and read these papers if they haven't. And importantly, there is a YouTube video that really summarizes everything. Thank you, Ravi, for your comment. Really appreciate it. And I want to thank those of you that attended this morning. These sessions are recorded, so certainly you can reach out. And I think the journal is trying this out as a new format of information gathering and information delivery. And if you think it's helpful and worthwhile, feel free to email anybody on the editorial board and say, this was great. We'd like to see this done in future. So thank you all. We'll let you get on to your day. Take care.